Welcome to A Doctor's Diary. Today, we're discussing a practical clinical guide to influenza, or the flu. Influenza is caused by viruses from the orthomyxovirus family, categorized into types A, B, and C. For human clinical practice, types A and B are the primary strains of concern. These viruses circulate globally. In temperate regions, they peak in winter, while tropical areas see activity year-round. Humans are the main reservoir, but the virus is in a state of constant mutation. Through zoonotic transmission, humans can contract strains circulating in animals, particularly influenza A. These cross-species mutations can trigger new strains capable of causing global pandemics. Transmission occurs primarily through respiratory droplets and aerosols released during coughing or sneezing. These particles target the nasal mucosa, oral cavity, or the conjunctiva of the eyes. The clinical onset is usually sudden. Let's look at the primary symptoms to watch for. Patients typically present with high fever, a dry cough, and a sore throat. Muscle pain and marked fatigue are characteristic markers of the flu. Runny nose and occasionally nausea or diarrhea may also occur. Influenza can lead to serious complications, extending beyond simple respiratory distress. Viral infection may be followed by bacterial superinfection, often from streptococcus or staphylococcus. Severe cases can cause cellular damage leading to rhabdomyolysis or viral myocarditis. These complications usually appear 3 to 10 days after the initial onset of symptoms. Risks are significantly higher for chronically ill patients and pregnant women. In children, while otitis media is common, severe respiratory failure can occur. Rare but severe cases in children also include myocarditis and encephalopathy. There is one vital clinical rule: never give aspirin or salicylates to children with influenza. This can trigger Rey syndrome, a severe condition involving encephalopathy and liver degeneration. Because symptoms mimic many infections, diagnosis relies primarily on laboratory testing. While sudden onset and high fever are suggestive, these signs are not specific on their own. The gold standard diagnostic method is PCR testing from a nasopharyngeal swab. Rapid antigen tests are available but have limited sensitivity and can yield false negatives. Treatment is mainly supportive, focusing on symptom relief and monitoring for secondary infections. Prevention, however, remains our most powerful tool against seasonal outbreaks. Vaccination remains the most effective preventive measure we have against influenza. Ideally, vaccination should be performed in October or November before the season begins. Annual vaccination is recommended for adults over 60 and those with chronic diseases. It is also vital for pregnant women and healthcare workers in high-risk environments. Most vaccines are inactivated and approved for use starting from 6 months of age. For children aged 2 to 17, a live attenuated nasal spray is a common alternative. Most modern vaccines are quadrivalent, protecting against 4 distinct viral strains. Common examples include Vaxigrip Tetra and Influvac Tetra. Efluelda Tetra is a high-dose option specifically for the elderly or immunocompromised. Early detection and annual vaccination are the pillars of influenza management. Thank you for joining me on A Doctor's Diary. I hope this practical guide aids your clinical practice. Don't forget to like and subscribe for more clinical insights. See you in the next video.